Welcome to this deep dive. Today, we're really getting into the British Society of Gastroenterology guidelines on colorectal surveillance in inflammatory bowel disease. Our mission, essentially, is to break down the evidence and the recommendations. It's all about optimizing care for IBD patients because they do face this documented higher risk of colorectal cancer.
Absolutely. It's crucial to state right up front that even with all the therapeutic advances we've made in managing IBD, that relative risk of colorectal cancer and dying from it, sadly, it's still significantly up there. We're talking, reports between 1.4 and 1.7 times higher than the general population. So this really highlights why effective evidence-based surveillance is just so critical.
It really does. And, colonoscopic surveillance, it's the cornerstone, right, for early detection, reducing risk. But there's this slightly odd finding in the data. The
Hmm.
post-colonoscopy CRC rates, they're actually reported as being up to six-fold higher than in sporadic cases, which,
Yeah,
yeah, makes you stop and think, doesn't it?
it does. It's a really interesting point. And this higher rate, it probably reflects a mix of things. Partly the challenge of spotting subtle changes in an inflamed, maybe structurally altered colon.
Yeah, it must be harder to see things clearly.
Exactly. And then there's the idea of maybe a faster progression path in IBD, inflammation, dysplasia, cancer, sometimes called accelerated carcinogenesis or field cancerization.
Field cancerization, right.
And importantly, we also know there's often, suboptimal adherence to the recommended surveillance intervals. People aren't always getting the checks when they should. Low concordance, that's a big area needing improvement.
Okay, so that's what we're aiming for in this deep dive, to really dissect these BSG guidelines, understand exactly when and how surveillance should happen. We'll structure it in three main parts. First, we'll look at starting and stopping surveillance, risk stratification methods, and, the intervals that follow from that.
All right. And second, we'll shift focus to the more technical side of the colonoscopy itself in the IBD surveillance setting. So bowel prep, which scope modality is best, how to spot dysplasia, and then what to do about it.
Okay. And finally, we'll cover the quality standards, what makes a good IBD surveillance service, and the practicalities of delivering that service, making sure these guidelines actually improve patient outcomes. All right, let's jump into part one then, the big question first. When do you actually start colorectal surveillance for someone with IBD?
Okay, so the guidelines say for patients with IBD that affects any part of the colon or rectum, you should start thinking about risk assessment for a surveillance program 8 years after their symptoms first started.
8 years from symptom onset. Got it.
But there's a key exception. Patients who have primary sclerosing cholangitis, PSC, along with their colitis.
Yeah.
For them, surveillance should be offered immediately when PSC is diagnosed. Their risk is just significantly higher right from the get-go.
Right, that immediate start for PSC colitis makes sense given the high risk. Now, what if the IBD isn't really in the colon? Say it's limited to the small bowel or just the rectum.
Good question. For Crohn's disease, that's definitely limited just to the rectum or the small bowel, or ulcerative colitis that's genuinely confined only to the rectum. Confirmed endoscopically routine IBD-specific surveillance isn't recommended. Those patients should just follow the standard colorectal cancer screening guidelines for the general population based on their age and other risk factors.
So the location and extent of the disease is really key for deciding who needs this specific IBD surveillance program. Okay, flipping to the other end, when do we think about stopping or at least formally reviewing the need for ongoing surveillance?
Well, there are a few triggers. One major one is if the patient develops significant comorbidities or becomes quite frail, to the point where the risks of the colonoscopy itself and any potential follow-up treatment might actually outweigh the benefit of finding an early-stage cancer, especially if it might be slow-growing anyway.
That makes sense. It's got to be about the whole patient picture, hasn't it? Are there things found during surveillance itself that might make you reconsider?
Yes, definitely. The guidelines recommend formally reassessing the patient's risk after every surveillance colonoscopy. It's particularly important after, say, 2 consecutive high-quality scopes that show no active inflammation, either visually or on biopsy. In those cases, you'd really question if continued surveillance at the same frequency is needed. Also, you'd review ongoing surveillance if someone develops significant other health problems between scopes or simply reaches the age of 75. Then you have to factor in life expectancy and other competing health risks.
Right, so it's not a one-time assessment. It's dynamic, needs regular review. Let's get into the specifics now, or risk factors themselves and how they dictate the surveillance intervals.
Okay, so that first surveillance scope, ideally at the 8-year mark or at PSC diagnosis, is really your baseline for risk stratification. The guidelines suggest you can use the classic approach, look at the single highest risk factor. Or, and this might give a more personalized picture, you could use a multivariate risk calculator. They actually provide a link to the Oxford IBD dysplasia risk calculator in the document.
Interesting. Using a calculator for a more nuanced risk, and based on that assessment, what are the interval recommendations?
They're tiered. For patients with persistent, severe active inflammation despite good medical treatment, or if that calculator flags them as having a large predicted risk of advanced colorectal neoplasia ACRN within 5 years,
Yeah.
then the guidelines actually suggest considering colectomy. The risk is just deemed that high.
Wow. Okay. Colectomy considered upfront for that highest risk group. What about the next tier down? Still significant risk, but maybe not quite warranting immediate surgery discussion.
Right. So for patients with moderate active inflammation, or if any dysplasia is found, or they have PSC, or a colonic stricture is seen endoscopically, or if the calculator puts them at a moderate predicted risk of ACRN at 5 years for all of those, the recommendation is annual surveillance colonoscopy, once a year.
Annual surveillance for that group.
Yeah.
Okay, and then for those with perhaps less pronounced risk factors.
A 3-year interval is recommended if there's mild active inflammation or extensive disease, which they define as UC extending beyond the splenic flexure, or Crohn's affecting over half the colon or 3 or more segments. Also in this 3-year group are people with a history of post-inflammatory polyps, or those with a small calculated risk of ACRN at 5 years. And importantly, this 3-year interval also applies if you have colonic IBD and a first-degree relative with colorectal cancer. Though a key point here, if that relative was diagnosed under 50, you really need to consult the specific BSG hereditary CRC guidelines, as they might recommend something different, possibly more intensive.
Ah, yes, the age of the relative is crucial. That could push someone onto a different pathway entirely. What about IBD patients who don't have any of these extra risk factors, the lower risk group?
For those patients, colonic IBD, but none of those specific risk factors we just listed, or their calculated 5-year risk is considered close to the general population risk, the recommendation is a colonoscopic reassessment every 10 years. But it's really important to stress they should also be participating in the normal age-appropriate population screening programs alongside that 10-year scope.
So it's a multi-layered approach, tailoring the frequency based on quite specific criteria. The guidelines also mention modifiable risk factors, don't they?
Yes, they do. Things like smoking, weight, alcohol. They make a point about smoking cumulative exposure measured in pack years is linked to a higher risk of neoplasia in IBD. The hazard ratio quoted is about 1.17 for every 10 pack year increase. So addressing these lifestyle factors is definitely part of the overall risk management picture.
And the thinking behind these specific intervals, like 1 year versus 3 years, what's the rationale?
Well, the evidence we have suggests that surveillance every 3 years, or more often, does reduce CRC risk and death compared to waiting longer. Plus, the fact that we still see higher rates of cancer detected after a scope, even at 3 years, suggests that longer intervals might just miss the window for effective early detection too often. And there's that concept again, the potentially faster inflammation dysplasia cancer sequence in IBD, maybe with this field catheterization effect, that supports more frequent checks for those at risk.
And the multivariate risk models, the calculators, they offer a more personalized way to estimate that risk, potentially.
That's the idea. They might give a more precise estimate for an individual patient, which can be really helpful for shared decision-making. Moving beyond just relying on the single biggest risk factor, which might not capture the full picture.
Okay, let's touch on a few specific high-risk groups mentioned. Perianal fistulizing Crohn's disease that gets a specific mention, right?
Yes. Patients with that pattern of Crohn's are known to be at higher risk of both anal and rectal cancer. So the guidelines recommend careful, regular clinical checks, paying close attention to any symptom changes. This means endoscopy of the area, imaging, and biopsies of anything suspicious, like tracts or lesions, to catch things early.
And colonic strictures, do they automatically mean higher cancer risk?
Well, finding a stricture always needs a thorough investigation scope, biopsies, imaging to rule out malignancy or high-grade dysplasia hiding within it. But the evidence suggests the stricture itself isn't an independent risk factor. The risk comes more from the underlying inflammation and any dysplasia that might be associated with it.
What about IBD diagnosed very young, in childhood or adolescence? Does that affect long-term risk?
Studies do show a higher relative risk, a higher hazard ratio, for CRC developing in adulthood if IBD started in childhood. That's seen for both UC and Crohn's. But it's important context. The actual absolute number of cancers happening before they transition to adult care is still pretty low. It's more about recognizing that long-term increased risk trajectory as they get older.
And finally, for this section, what if a patient has both IBD and a known hereditary cancer syndrome like Lynch syndrome?
That's a complex situation needing careful management. Their surveillance should primarily follow the specific BSG guidelines for hereditary CRC syndromes. The combination of chronic inflammation from IBD and the inherited genetic risk can really increase their overall cancer risk, potentially needing a different, maybe more intensive surveillance plan than for IBD alone.
Right, that makes sense. Okay, that gives us a really solid grounding in surveillance timing, risk stratification, and intervals. Let's move into part two, the nuts and bolts of the colonoscopy itself and managing dysplasia. First step, always crucial, bowel preparation. Any specific recommendations there for IBD patients?
Yes. The guidelines suggest either low-volume, PEG-based preps, that's 2 liters or less, or non-PEG options are both acceptable. Trials haven't shown a big difference in how well 2L versus 4L PEG preps clean the bowel. But interestingly, patients seem more willing to repeat the prep next time if they've had the lower volume, which could be good for long-term adherence.
Good point about adherence. What about the non-PEG options?
There are non-PEG sulfate-based preps available. They seem to perform comparably to the low-volume PEG options in terms of effectiveness, how well patients tolerate them, and their willingness to use them again. Choosing the right prep really needs to be individualized, though. You need to consider patient preference, previous tolerance, how active their IBD is, any risk of electrolyte problems, past surgeries, things like that.
Okay, prep sorted. Now, the scope itself. What technologies should be used?
High definition, or HD, endoscopy. That's strongly recommended over standard definition for finding both dysplasia and cancer in IBD. One study found HD scopes detected dysplasia in roughly twice as many patients compared to standard definition. That's a big difference. And going a step further, the guidelines suggest using dye-based high-definition chromodoscopy HD-DCE over just HD white light, HDWLE.
Dye spray chromondoscopy. Why is that preferred?
The thinking is that HD-DCE might help spot a few extra, potentially subtle dysplastic lesions that you could miss with white light alone, even high-definition white light. There was a network meta-analysis supporting this, showing HD-DCE was better for detecting any dysplasia, though the evidence certainty was graded as low. Still, it's the suggested approach.
What about virtual chromondoscopy? Things like NBI, FIC, iScan.
The guidelines don't make a formal recommendation for or against using those routinely in IBT surveillance right now. The reason is the evidence supporting their utility, specifically in this context, is currently considered very low certainty. We basically need more high-quality studies to figure out their true role.
Okay, so HD is key, and dye spray chromo is suggested. Now, how do we actually find the dysplasia during the scope? What biopsy strategies are recommended?
Well, it depends a bit on the risk profile. In high-risk situations, like someone with previous dysplasia or PSC, they suggest considering taking quadratic, non-targeted biopsies every 10 centimeter or so, or from each segment. That's in addition to carefully targeting anything that looks suspicious. But for general surveillance, if you don't have those high-risk features or obvious lesions, targeted biopsies guided by dye spray are generally thought to be more effective at finding dysplasia than just random non-targeted biopsies alone. Random biopsies might still add value sometimes, though, like in those high-risk patients we mentioned, or if the view is difficult due to inflammation.
Once you get a biopsy showing dysplasia, the pathology report is obviously critical. Any specific points for pathologists looking at IBD dysplasia?
Yes, several important ones. Pathologists need to look for and report both conventional and non-conventional dysplasia types. And because it can be tricky and the implications are significant, double reporting is strongly recommended for all dysplasia cases. That means a second pathologist, ideally a GI specialist, reviews the slides.
Double reporting for confirmation. Makes sense. What about serrated lesions? How do they fit in?
All right, this is important. Non-dysplastic serrated lesions found during IBD surveillance aren't currently thought to be IBD-related cancer precursors. They should just be managed like sporadic ones found in the general population. Finding serrated epithelial change, or SEC, alone without dysplasia shouldn't automatically increase surveillance frequency. However, if you find SEC with dysplasia, or it looks hypermucinous or villiform, that needs discussion at the IBD multidisciplinary team meeting, the MDT, and a repeat scope with an expert endoscopist. And SSL's sessile serrated lesions without dysplasia, again, manage them as sporadic. Critically, any dysplasia diagnosis within the colitis area should trigger referral for discussion at the IBD MDT. That's really key for planning management. Oh, and pathologists might consider using P53 staining as an extra tool to help distinguish true dysplasia from just reactive changes caused by inflammation.
The MDT discussion seems central here. Okay, so if you find a visible dysplastic lesion in an area of colitis, what's the approach to managing it endoscopically?
If you see a clearly defined lesion that looks dysplastic, but doesn't obviously look like invasive cancer, the strong recommendation is to aim for endoscopic resection, preferably en bloc, meaning in one piece. Getting complete endoscopic removal is associated with a really low risk of cancer developing later. The pooled risk is about 0.2 per 100 person years. Very low. For bigger lesions, say 2 centimeters or more, especially if they're flat or non-polypoid, you'll likely need advanced techniques like EMR, endoscopic mucosal resection, or ESD, endoscopic submucosal dissection, or maybe a hybrid approach to get it all out in one piece for proper staging. And routinely biopsying the normal-looking mucosa right next to the polyp after you've removed it. That's generally not recommended.
Okay, so endoscopic resection is the goal for visible, non-invasive looking lesions. When does the conversation shift towards considering colectomy for dysplasia?
Surgery, colectomy, comes into play when the risk of current or future cancer is thought to be substantial, and endoscopic methods either aren't feasible or seem unlikely to be curative. Deciding on the timing of surgery has to involve a really thorough discussion about the ongoing risks of neoplastic change, so it's proper shared decision-making. Specific reasons to discuss surgery would include visible dysplasia that you just can't manage endoscopically, finding high-grade dysplasia, finding multiple separate areas of dysplasia, multifocal, or if dysplasia was removed piecemeal, raising concern about residual disease, or, of course, patient preference after understanding the options. The extent of surgery, whether it's removing just a segment or the whole colon and rectum, depends on the dysplasia grade and spread, the IBD itself, other health issues, and patient preference. But if you do limited surgery, you absolutely need intensive surveillance afterwards.
Are there any biomarkers helping guide decisions once dysplasia is found?
In haploidy analysis, looking for abnormal chromosome numbers in the dysplastic cells shows some promise. It might help predict which lesions are more likely to progress, but it's not routinely available or standardized for clinical use yet. It's still more in the research phase. We need more work before it becomes part of standard practice.
Got it. So after dysplasia is found and dealt with, what's the recommended follow-up surveillance plan? It sounds like it varies quite a bit.
It does, yeah. It really depends on what was found. If it was high-grade dysplasia, HUD, or low-grade dysplasia, LGD, but with high-risk features like being large, 2 centimeter, non-polypoid, multifocal, or removed piecemeal, then you do a follow-up scope in 3 to 6 months. If that's clear, then you go to annual scopes for 5 years. Now, if it was unifocal and visible LGD, meaning found on random biopsy, not a visible lesion, and it's not confirmed on a careful repeat scope within 3 to 6 months, the follow-up is a bit less intense. Repeat scope at 3 to 6 months, then annual for 5 years if still clear. But if invisible LGD is confirmed as multifocal, or it keeps recurring, you manage it like multifocal invisible LGD. And for invisible HD or confirmed multifocal invisible LGD. The strong recommendation is urgent proctocolectomy because the risk of hidden cancer is high. If the patient refuses surgery, then you offer very intensive surveillance, like scopes every 3 to 6 months. Finally, if the diagnosis is indefinite for dysplasia or IND, confirmed by 2 pathologists, first you optimize medical therapy to reduce inflammation, then repeat the scope in 3 to 6 months with targeted and mapping biopsies. If it's still IND, you continue annual surveillance until the inflammation is controlled. If the repeat scope is negative, you can consider de-escalating surveillance frequency.
That's quite detailed stratification for follow-up. What about patients who've had surgery already, say an ileoanal pouch, IPAA, or they still have their rectum after subtotal colectomy?
Good points. For patients with an IPA pouch after UC surgery, routine surveillance isn't usually needed for the first 10 years unless they have specific risk factors. Those risk factors include a history of previous colorectal neoplasia, having PSC, chronic pouchitis or cophitis, Crohn's involving the pouch, a long duration of UC before surgery, like 8 years, or a family history of CRC and a first-degree relative. If surveillance is needed, it should be done by experienced endoscopists with biopsies from the pre-pouch ileum, the pouch itself, and the cuff area. For patients with a retained rectum after subtotal colectomy, yes, there's an increased risk of neoplasia there, especially if they had neoplasia before surgery. The general recommendation is annual scope or sigmoidoscopy for the first 5 years, then maybe every 2-3 years after that, depending on individual risk.
Okay, that covers the technical and management aspects thoroughly. Let's move to the third and final part. Quality standards and service delivery, making sure all of this happens effectively in practice.
Exactly. Quality assurance is heavily emphasized, Endoscopists and units are encouraged to track their performance using key performance indicators. KPIs may be adapted from the European Society of Gastrointestinal Endoscopy ones. Things like, was the indication appropriate? Is the photo documentation good? What's the ileal intubation rate? Are enough good biopsies being taken? Are activity scores being documented? Is HD always used? How good is the bowel prep? How often is chromoendoscopy used?
So benchmarking individual and unit performance, are there specific targets for the service overall?
Yes. The guidelines suggest some performance standards, like aiming to offer the first surveillance scope within 8 years of diagnosis, or at PSC diagnosis, and subsequent scopes within 6 months of their due date, hitting that for at least 70% of patients, ideally 90%. Another target is that all dysplasia cases, including those initially called indefinite, should be discussed at an IBD MDT meeting. The minimum standard there is 95%, aspirational is 100%.
And patient feedback is important too.
Absolutely crucial. Collect patient-reported experience measures PREMs and use that feedback to improve the service. Other key quality measures for the colonoscopy itself include achieving good bowel prep consistently, like a Boston score of 6 or more, with at least 2 in each segment, and aiming for a dysplasia detection rate, finding LGD, HDD, cancer, or non-conventional dysplasia of at least 8% based on published benchmarks. And just to reiterate, you don't count non-dysplastic serrated lesions in that DDR target.
Okay, focusing on service delivery now. What are the big challenges and recommendations there?
Well, the fundamentals are ensuring patients actually get timely surveillance based on their risk, and that any dysplasia found is managed properly according to the guidelines. A major challenge is patient concordance, getting people to come back for their scopes when they're due. Education and effective reminder systems are key here. There's some suggestion that higher volume centers might do better on concordance. And we have to remember, delayed surveillance is a really big reason why we see post-colonoscopy cancers develop. Timely access is critical.
Training for endoscopists performing these specialized scopes is also addressed.
Yes, definitely. There's a need to develop specific training programs for IBD surveillance colonoscopy. And services should regularly audit the performance of their endoscopists doing these procedures. Auditable things would include use of HD, use of dichromo, documenting activity scores, bowel prep quality.
What about sustainability, the idea of green endoscopy?
It gets a mention. The idea is that using a targeted biopsy strategy, guided by chromoendoscopy, is likely better for the environment than taking lots of random non-targeted biopsies, mainly because fewer pots and pathology resources are used. And while following the guidelines might mean more initial surveillance scopes, hopefully it leads to fewer unnecessary or badly timed scopes later on, balancing out the resource use and making practice more sustainable overall.
Is IBD surveillance considered cost-effective?
The current thinking, based on economic models, is that yes, it likely is cost-effective, meeting standard Nissen thresholds. Things like using longer intervals for low-risk patients and using chromoendoscopy with targeted biopsies might actually improve cost-effectiveness further. Though, these models always have underlying assumptions about disease progression that might have some uncertainty.
And finally, back to the patient experience. What's key here?
It's recognized that colonoscopy can be particularly burdensome for IBD patients, maybe more embarrassing, uncomfortable, or painful. So services really need to listen to patient feedback via PREMs and act on it. Key things are good discomfort control during the scope, ensuring the endoscopist is skilled specifically in IBD surveillance, and really clear, empathetic communication throughout the whole process.
This has been incredibly thorough, a really deep dive into these BSG guidelines. I think the overwhelming message is that personalized, risk-stratified surveillance is absolutely key for preventing colorectal cancer in IBD patients.
Absolutely. That personalized, risk-based approach, combined with high-quality colonoscopy technique, careful MDT-guided management of any dysplasia found, and a real focus on service delivery and patient experience. That's the heart of it. The goal is clear: improve outcomes and reduce the burden of colorectal cancer for people living with IBD.
And it's important to remember this field is constantly evolving, isn't it? New research is always emerging. The guidelines themselves point out areas needing more study.
That's right. They list several important research questions, like understanding post-colonoscopy cancers better, finding ways, maybe digital tools to improve surveillance adherence, comparing different risk calculators, looking at sex differences in risk, the combined impact of IBD and hereditary syndromes, potential chemo prevention with 5-ASAs, optimizing lifestyle factors.
Lots still to learn.
Improving bowel prep, the role of AI in detection, new biomarkers, the significance of serrated changes in non-conventional dysplasia, how long to continue intensive surveillance after dysplasia. Yeah. Plenty to keep researchers busy.
So, as we wrap up, perhaps something for you, the listener, to think about is how this combination of individual patient factors and rapidly advancing technology will continue to shape IBD surveillance. We're clearly moving towards ever more personalized and hopefully even more effective ways to prevent colorectal cancer in this group. Thank you for joining us for this deep dive. Welcome to this deep dive. Today, we're really getting into the British Society of Gastroenterology guidelines on colorectal surveillance in inflammatory bowel disease. Our mission, essentially, is to break down the evidence and the recommendations. It's all about optimizing care for IBD patients because they do face this documented higher risk of colorectal cancer.
Absolutely. It's crucial to state right up front that even with all the therapeutic advances we've made in managing IBD, that relative risk of colorectal cancer and dying from it, sadly, it's still significant.